So it's an honor and a privilege to introduce our friend and colleague, Professor Gareth Evans from the University of Manchester, who's going to give us a talk on clinical gender and molecular features of NF2 results of over 1,600 patients. Gareth's been a leader in the NF2 world for many, many years, and we appreciate him taking the time to talk with us. So Gareth, thank you very much.
Bill, it's a pleasure. So I'm just going to go through data that we have, or that I've accumulated since 1990, since I went around the UK visiting NF2 patients and their families as part of my MD thesis, and obviously have worked with NF2 ever since. So one of the things that I guess we need to be saying now is that we mustn't use the word neurofibromatosis anymore, because NF2 has now been renamed as NF2 related schwannomatosis. So we now know that neurofibromas are not part of NF2. It should never have been called neurofibromatosis in the first place. But there are, there is a need for comparisons with the bedfellow that we've sat with for so long. It is about 10 times less common. Slightly more cases are de novo, particularly if you allow for the mosaic cases who do not present with classical bilateral vestibular schwannomas. It's often late onset compared to being usually recognized early in NF1. Often nothing in the skin, but if you have your NF2 BDI out, you can often see stuff in the skin. There is a low-grade malignancy rate with ependymoma, but much less than the malignancy rate that's associated with NF1. And obviously, the gene was cloned a little bit after, about 3 years after the NF1 gene in 1993. So obviously, the classical lesion are these bilateral vestibular schwannomas in the CP angle. And you can see here just relatively small tumors, not causing much brainstem compression. And this is the classical feature. It is the thing that gives the NF2 its sort of name. The vast majority of patients with NF2 will develop bilateral tumors, and about 85 to 90% are diagnosed with bilateral tumors at presentation. So the tumors occur on both branches of the vestibular nerve. You do occasionally get cochlear schwannomas. Growth rates are very variable. They tend to be highest post-puberty to around 25 years of age. And they're quite slow growing in infants and young children, and they start to grow slower later on. But that hides the fact that they can sometimes, even in older people, grow very rapidly. So I don't know if you can see this slide completely, but we published this a few years ago. This is a patient who was having screening, who had a family history, aged around 12. And you can see here 3 dots on the inferior vestibular and about 5 dots on the superior vestibular, and something fairly similar on the other side. And these multifocal tumors that have been described for many years as these lobulated masses that go around the facial nerve are one of the reasons why surgery and radiation treatment are more complex and difficult in NF2 than they are in sporadic tumors. And they are multifocal from the get-go. So how do people with NF2 present? And this is from my own personal series of 596 patients I've seen. About 60% present with symptoms attributable to vestibular schwannoma, either hearing loss, tinnitus, or imbalance. Around 15% develop meningioma symptoms as their first symptoms, seizures being not uncommon, headaches or visual loss, for optic meningiomas in particular. And then pain and paresthesia are presenting features for and weakness for spinal tumors, and again about 15%. And then there are a number that present, particularly in childhood, with mononeuropathies, and something that we need to be aware of, often the first presenting feature in childhood. And in terms of age of onset, this is again in 600 patients that I've seen. You can see here that around 10% of patients with NF2 present after the age of 45, and around 15% present in childhood. Sorry, 25% present in childhood. So a bit of a timeline for NF2, and a little bit about what Manchester has contributed to. The first case probably it was in Scotland, reported by Wishart in 1822. And the main confusion between NF1 and NF2 was, I'm afraid, due to a very, very famous neurosurgeon, Harvey Cushing, who basically said you get bilateral tumors in the CP angle in von Recklinghausen disease. And because he was so famous, it took years and years and years to unpick NF1 from NF2. And it really wasn't helped by many series, such as the series of Crow in 1956, actually including bilateral acoustic neuromas as they were then in the NF1 series. But it became clear in 1987, with a separate location of NF1 and NF2 to different chromosomes, that we were dealing clearly with two different conditions. I carried out the first large epidemiological study of in Manchester, from Manchester in the UK. The NF2 gene itself was cloned in '93, and obviously auditory brainstem implants, pioneered at the house. So I can't claim that that was a Manchester thing, but Richard Ramsden, Dick Ramsden in Manchester was a major early pioneer of that as well. We described mosaicism for the first time in NF2 in 1995, and lots of phenotype papers published in 1996, including from the US. We did the first large mortality study in 1998. And the first successful drug treatment with bevacizumab was reported from Scott Plotkin in Boston. And we were able to commission our own national service for NF2 in 4 centers. So that's 68 million people looked after in 4 centers in the UK, with Manchester as the lead. And we were able to get bevacizumab approved for use in NF2 in rapidly growing vestibular schwannomas in 2010. And we have just published the new diagnostic criteria for NF2, which have updated the Manchester criteria that we published in 1992. So these are the 92 criteria. In the sort of dark blue here are the original NIH criteria. And you can see that unless you have a family history, you can only be diagnosed with NF2 with bilateral vestibular schwannomas. So what we did was to allow the possibility of NF2 in a sporadic case if they had a unilateral tumor and 2 other NF2 related features, including 2 tumors of the same type, or multiple meningiomas and 2 or more other features. And in fact, multiple meningiomas is a better criterion, as I'll show you later on, than unilateral vestibular schwannomas, a major criteria. And one of the things that prompted us to have to change the criteria were that in LZTR1 schwannomatosis, many, well, not many, but a number of cases developed vestibular schwannomas. So we were able to show in our first paper in neurology that 3 cases had vestibular schwannoma as well as other schwannomas. And a larger series we published showed that in 39 individuals with unilateral vestibular schwannoma and 2 or more schwannomas with no germline NF2 or mosaic mutation, we identified a number of different individuals. And in 5 tumors from germline mutation negative patients, we were finding these mutations. So overall, 5 out of 50 who with unilateral vestibular schwannoma and other schwannomas had an LZTR1 heterozygote mutation rather than an NF2 mutation. And in fact, it was as common to have a heterozygote LZTR1 mutation as a heterozygote NF2 mutation. But a sizable proportion of the rest of these patients do have mosaic NF2, where the genetic fault has occurred after conception during embryogenesis. And this is just showing you some of these are the cases. I think the bottom one's dropped off the slide, off the bottom here, but you get the typical NF2 hits in the tumor, but different NF2 hits in each tumor, other than the loss of the normal copy is on the same copy each time. And these are the inherited LZTR1 variants. We've not yet found a single individual who's been mosaic for an LZTR1 variant. And just showing you the split here, LZTR1's a quite difficult gene because it's actually very commonly mutated in the germline in population series, about 1 in 280 people in NOMAD, the big population database, have potentially pathogenic variants. And this sort of may partly explain this very big difference that when we look at inherited schwannomatosis cases, they virtually account for the same proportion each. About 70% of all inherited are explained by the 2 genes, but many more sporadic cases have LZTR1 rather than SMARTB1. So I've touched on the mosaicism issue. We found that essentially 50% of patients with no germline SMARTB1 or LZTR1 who have 2 tumors tested have mosaic NF2. So in individuals who meet schwannomatosis criteria with no vestibular schwannoma, just multiple schwannomas, about half of them that don't have LZTR1 have mosaic NF2. And that's here, the 20 out of 36 here. And that's because we find identical NF2 pathogenic variants in different tumors from the same individual. And this is just a series of them. I'm not going to go into detail, but just to show you that the vestibular schwannomas in these cases occurred after the development of multiple other schwannomas. And these are the underlying NF2 variant that was found at low level, often not identified in blood, only identified in the tumor. So we have changed the diagnostic criteria, and these are the new criteria. There was an argument to not include bilateral vestibular schwannomas at all ages, because we published a case that had 2 different NF2 variants in the tumor in someone presenting at later ages with just bilateral vestibular schwannomas. And we think that over 50% of individuals who present with their second tumor or both tumors over the age of 70 are chance associations rather than NF2. So these have developed 2 separate tumors by chance rather than having NF2. And we know that if you do post-mortem studies in much older people or MRI studies in much older people, then vestibular schwannomas are much more common than the lifetime incidence that is often published at around 1 in 800 to 1,000. So we have now got these major criteria. So this is an adaptation of the Manchester criteria: unilateral vestibular schwannoma, first degree relative other than a sibling with NF2 schwannomatosis, NF2 pathogenic variant in an unaffected tissue, and 2 or more meningiomas. So you can see those 2 criteria remain. And you can then have minor criteria. So you need 2 minor criteria. That includes ependymoma and schwannoma. That can be accounted for. You can count twice. You can only count a meningioma once if it's a non-meningioma major criteria. And then you have these ophthalmic criteria: juvenile subcapsular or cortical cataract, retinal hamartoma, or epiretinal membranes aged less than 40 years of age. And this just shows you the additional criteria again here. And the clarification is that we have removed neurofibroma and glioma because they are ependymomas, not gliomas. We do get the occasional low-grade glioma, but they are hugely less than ependymoma as part of NF2. So a little bit on the epidemiology. We were able to, we set up a register for NF2 in 1990, and we were able to look at cancer registries as well as hospital records to assess the incidence of NF2 in our region. We've done various papers over the years, the most recent in 2019, where we estimated a birth incidence of around 1 in 28,000. So within, very close to the original publication, slightly lower than our publication in 2005 based on vestibular schwannoma incidence. But here you can see the prevalence has gradually been increasing. And that's because we're diagnosing at earlier stages, and we're, we hope, allowing NF2 patients to live longer with better specialist care and treatment. So in our region of 5 million, we have 1 in 50,000, and we've now looked at the whole UK, and because we manage them all in 4 centres, and essentially in a population of 68 million, it is very close to that 1 in 50,000 figure. So what about survival? So we published this paper in 2012, where we looked at deaths in our local population, and I know that Bill's published showing that a lot of these deaths are related to lower cranial nerve dysfunction, and 24 of the deaths out of 34 were essentially likely caused by NF2. 10 were non-NF2 related deaths. Median life expectancy in the groups were 35.9 in the NF2 related deaths and 72.5 in the non-NF2 related deaths. We also published this paper a few years ago showing the NF2 survival here in green being quite a lot worse than NF1 in blue here, and in Gorlin syndrome, another tumor predisposition syndrome. Not quite as bad as von Hippel-Lindau here, which would be interesting to the neurosurgeons, that actually it's got lower survival in our region. And then in 2015, we published another paper on survival by mutation type. And this showed that truncating mutations, so mutations that truncate the protein, what are called nonsense and frameshift variants, have a much worse survival than individuals with large deletions, which take out chunks or the entire gene, and splicing variants. So these change the splice sites and may delete an exon or multiple exons, again, usually causing a truncated protein. And then the missense variants just change 1 amino acid. So the missense variants are not far off normal life expectancy here, but all of these clearly in heterozygote form, not mosaic form, reduce life expectancy. And when we divide up the truncating mutations into those in exons 2 to 13, we see really poor survival. And No patient has so far lived beyond 65 years of age with one of these variants. But if you get an exon 1 variant or an exon 14 to 15, there is significantly better survival. And we think this is due to the dimerization of the abnormal product here with the normal protein. So there is not nonsense mediated decay. There is, for at least a short period of time, enough truncated protein to produce that it actually causes what we think is a dominant negative effect, taking out the normal functioning NF2 wild type protein. So this just goes into a bit more depth about that. There were 7 out of 37, 19% living patients with full constitutional mutations in these early deletions in exon 1. We think there is probably a reinitiation codon, so that there's only a small chunk of the exon 1 missing from the protein. And this is also showing a positional effect for splicing variants, with splicing variants later in the gene causing much less severe NF2 than those earlier in the gene. And when we look at survival based on the era of diagnosis, we started our highly specialized service in 2010. Obviously, it's a bit early to look at survival because they've only had 4 years to die. But we did see a clear era effect with patients diagnosed in 1980 to 89 having worse survival than those in 90 to 99 and 2000 to 2009. And that this was despite the fact that actually patients in these earlier eras had better mutations, so less severe mutation types. So we've now updated this analysis to 2022, so this is unpublished data. 570 patients diagnosed in the UK since 2010. Only 20 of those have died, and you can see a large number of these deaths are in typical non-premature age deaths, and these are not NF2 related. But there are now creeping in these young deaths. So these individuals have survived long enough from diagnosis to die from their severe NF2 at younger ages. But only 9 of these 20 deaths were definitely NF2 related. There's a question mark whether there might be a slight increased risk of cerebrovascular deaths, and there were 2 stroke deaths at 47 and 50. But there's still very significantly better survival than the previous death rate, and only 8 out of 524 deaths were premature within 10 years. So we have a target that less than 5% of our deaths are premature NF2 deaths within 10 years of diagnosis. So these are the actual deaths. You can see here that the earliest death, almost certainly not NF2 related. We don't think there is a link with breast cancer. But then a lot of the tumor burden, and I'm sure that some of the lower cranial nerve dysfunction is contributing to some of these deaths. When we look at the deaths by era of diagnosis, you can see the mean age of death has advanced considerably, as has the median age of death. And you can see that there is a highly significantly better survival in the current era than the 2 previous eras. So we looked at COVID deaths. So there have been 1 COVID death in our 982 patients, compared to 1 in 480 in the UK. Obviously, we have less elderly patients, but there's no clear evidence that NF2 are more or very vulnerable to COVID-19. So the NF2 related premature deaths, this is our Kaplan-Meier showing this. And again, you see this significant difference in Kaplan-Meier between the current era and previous era. And this is the overall actuarial survival in those diagnosed since 2010. So again, this does not look desperately different from the survival in the normal population. And again, showing you that overall actuarial survival by era, very significantly different. No real evidence of a difference between men and women, although you could say that because women typically survive 4 years older than men, that might mean there is an effect. And you can see there's a bit of a separation with men living a bit longer in the the longer time periods from diagnosis. So there may be a little bit of an effect there, maybe from multiple meningioma disease in women. So when we look at the types of mutation, this is analysis from over 1,600 individuals with NF1, with NF2, from over 1,300 families. You can see here the predominant variant type is nonsense variants. And you've heard from before, these are the bad ones. These tend to give you the worst disease. And we see our sort of more favorable missense variants being quite uncommon as a cause, quite a lot of splicing and large deletions. When we move to the second generation in 170 families, you can see the nonsense mutations have disappeared right down the list. That's because they're so severe, they affect genetic fitness. So these individuals don't tend to have children because they're already severely affected at the time when they're likely to be thinking or having children. And so the splicing variants actually become the most frequent variant, and you can see missense pretty well represented now compared to the other variant types. So it's really important to also note that when we do analysis in this generation, if we do the standard test which is a next generation sequencing of all the exons and intron exon boundaries, and a test to look for large deletions and duplications, we detect around 91% of the variants in the second generation. However, we found a whole range of other variants that were missed that we pick up by doing other tests. So chromosome analysis actually found 2 translocations through the middle of the gene. There were 3 inversions, so where the DNA switches around, so the code is all there, but it's actually been turned around and the sequencing doesn't tell you that. So there were 3 of those. There was an inversion in the 5' region that was not even detected on RNA because there was no product to actually look for. And then we found a number of deep intronic mutations, including 232 base pairs into the intron that no one would be looking for. And then 2 variants before the start of the gene that have now been shown by a study by Nicola Whiffin to switch off the promoter. So again, this is the mosaicism story continued, that obviously germline mutations, the mutation is present in the egg or the sperm, and all the cells carry the variant. Half of the gametes do, so it's a 50-50 chance of transmission. Where the variant is not present in the germline, it can occur in the embryo and cause somatic mosaicism and might just affect a patch of that individual. Now, if it affects your shoulder in NF2, you're probably okay. The problem is if it occurs early enough in embryogenesis, it may be at low level in all cell types. And that's what we see in quite a lot of patients with NF2. In over half of the mosaics, we find very low level in blood, and it's almost certainly in all tissues. But in about 40%, we only find it by looking in the tumors, and we find identical mutations between the tumors. So obviously, this gene, for whatever reason, has an extremely high de novo mutation rate. and previously reported series suggested about 25 to 33% were mosaic. Now we've now proven 283 out of 1,200 are mosaic, 1,200 de novo cases. And when we do the calculations based on our current analysis being around 90 to 91% sensitive, we're able to show that around 50% of all bilateral vestibular schwannoma patients with no delay between the sides have mosaic NF2. In all of the other types where there is asymmetric presentation, we see much lower. So if they present with a unilateral vestibular schwannoma and other tumors, it's as high as 80%. If they present with unilateral vestibular schwannoma and diagnosis with other features such as meningiomas, 73%, and so on. So in total, nearly 60% of all de novo patients with NF2 who meet diagnostic criteria actually are predicted to be mosaic. And age is obviously important. If you present under 20, we know that essentially only 6% of those are mosaic, so there's close to a 50% chance of transmission. As they get older, it rises to 16%, age 20 to 29, 31% age 30 to 39, 63% over the age of 40, and you can see here the unilateral group much higher at 83% over the age of 40. And again, the transmission rates are dropping in children as the rate of mosaicism rises. So we talked about the effect of the variant type. You've got here the truncating variants again with this much earlier mean age of onset and mean age at diagnosis, and with the missense variants just changing one amino acid in the protein around double the mean age at diagnosis, double the mean age at mean age at symptoms and mean age at diagnosis. And the mosaics end up around the same as the missense variants, but missense variants actually often a little bit milder than some of the mosaics who typically have truncating variants in blood. So is there an effect on meningiomas? Well, yes, there's an effect on meningiomas, which is position sensitive. If you have mutations in the last two exons, a much lower risk of meningioma, which almost certainly contributes to that lower death rate in that group. And this is again showing you that it does appear, and this is because exon 1 here is mild, that you don't see exons 1 to 3 worse than exons 4 to 6. So if we took the ones out, the blue would be almost exactly the same as the red here. But when you think about meningiomas, you always think it's worse in women. Well, actually, for the first meningioma in a patient with NF2, women only catch up in their 50s. They get more, but they don't get there first as early. So you can see this much earlier onset of meningiomas in males compared to females. Significantly higher at 25% of males compared to 15% of females by the age of 20. And this is published, although quite well hidden in the sporadic population as well. So we have done some more recent work on meningiomas that I mentioned. Again, 1,622 patients meeting NF2 criteria, 131 met criteria with a unilateral vestibular schwannoma and 2 or more meningiomas. 96 met the criteria with the presence of other schwannomas plus an initial UVS, but no meningiomas. And we have never yet, so far, disproven that anyone with unilateral vestibular schwannoma and 2 or more meningiomas have NF2. However, 11 out of 96 of those with unilateral vestibular schwannoma plus 2 or more other schwannomas and no meningiomas have been excluded as having NF2. 7 have a germline LZTR1 variant, and 4 have discordant NF2 variants between 2 tumors, essentially excluding a single NF2 variant as causing their problem. And that's highly significant. There was a marked female predominance in this meningioma group of 77%, significantly higher than the 46% of women in the schwannoma group. And there was molecular proof for NF2 at around 49%, which was a bit lower than in the meningioma, in the schwannoma group. And this is just showing that obviously in these older patients where we don't have access to 2 or more tumors, we often aren't able to come up with a definitive diagnosis. But I think the vast majority of these patients do have NF2. So we'll move on to the treatments now. This is our treatment with bevacizumab that we've published in growing vestibular schwannomas by at least 60% annually. And you can see this waterfall plot showing the great majority of these tumors from a 60% growth annually reduced to below to negative growth, in other words, shrinkage. And many of them meet RECIST criteria here, 39% of the tumors meeting the RECIST 20% reduction criteria. And this has had a really remarkable effect on our use of vestibular schwannoma operations and of radiotherapy. So this was the amount of surgeries we were doing in NF2 in Manchester, peaking here in 2008. And with bevacizumab in 2010, this rate of operation, despite the fact we were actually now dealing with many more NF2 patients covering the whole of the north of England, a population of over 18 million, the VS operation rate has gone right down, and with the eye of faith, maybe a few less radiotherapies. And the time to first VS intervention, surgically or RT related, you can see here, substantially different now that we have Avastin as a potential first-line treatment. So what about radiation? So I'm not sure if there are any radiotherapists here or people who use radiation, but maybe now's the time to leave or at least close your ears. So we have been able to now assess radiation treatment in the UK in NF2 patients over a period of certainly prospectively since 1990, since I've been involved, but we've been able to capture some retrospective treatments as well. And cases where NF2 patients treated with radiation for benign CNS tumors. Controls were matched for treatment location with surgical medical treatments based on the age and year of treatment. Prospective data collection began in 1990, as I said, with retrospective cases going back to 1969. We performed Kaplan-Meier analysis for malignancy incidence. So we defined malignancy where there wasn't pathology available, where the patient had died, where the annualized growth was 2 centimeters in diameter in 1 year. So there were 1345 NF2 patients in the UK, 266. Half of them male had undergone radiation between 1969 and 2021, with median first radiotherapy at 33. There were 9 subsequent CNS malignancies, malignant progressions, which were identified in cases, with only 4 in the 1079 untreated patients, which was highly significant. The lifetime and 20-year CNS malignant versus malignant progression was close to 6% in irradiated patients versus less than 1 in non-irradiated patients. And in the matched case control study, there were no malignancies in the matched group. Again, that was significant. The 30-year survival from index tumor treatment in cases versus controls was significantly better in the controls versus the cases. And these are the Kaplan-Meier. So these are all the NF2 patients as controls, with these 4 malignancies occurring in the CNS, and these in the radiated group. Again, in the matched case control set, you have the Kaplan-Meier curve here. And when we look at survival, this is the survival curve. Again, there is separation here. So no evidence that having radiotherapy is actually better for survival, if anything, worse for survival, with 30-year survival of 45% versus 66%. And importantly, although we were not able to match for tumor size at treatment, we know that, of course, we operate on far larger tumors, particularly far larger vestibular schwannomas than we would ever irradiate, with an agreed maximum tumor size of 3 centimeters, although there were 1 or 2 that slipped through at 3.5 centimeters in the radiation group. But also the NF2 patients who were irradiated have better molecular profiles. So they actually had better types of mutations, more mosaics, less with the severe mutation types. And when we look at vestibular schwannoma alone, because there were 2 spinal progressions of ependymoma with malignancy in the irradiated group, you can see still a significant difference here, with about a 5% malignancy rate by 20 years in the irradiated group. And this is showing no significant survival in the VS-only group. And these are the tumors. I can't really go into all the detail on this slide, but just to show you, this was a glioblastoma in the radiation field in a patient with vestibular schwannoma, radiation, malignant progression of an ependymoma, a schwannoma that became malignant in the vestibular schwannoma, and these have been previously reported, so these are not new cases. This is a Sheffield case that developed MPNST in a vestibular schwannoma 3 years after treatment. And a grade 3 meningioma right next to the vestibular schwannoma radiation, which we've just treated, incredibly fast growing tumor. And again, the more recent MPNST here, dying 7 years post radiation. This is one of the published cases showing you a tumor here that had significantly shrunk by about 5 millimeters 18 months after radiotherapy with central necrosis. And then 18 months later, you see this massive growth. And it's hard to believe this is anything other than malignancy. There was no post-mortem, so we can't be certain, but this is certainly malignant progression. And this patient actually presented moribund in hospital. So what about age of treatment? Well, 2 of the 32 patients having radiotherapy less than 18 developed malignancy, 5 out of 67 of those under 23. So there does possibly appear to be an effect here, with those being irradiated later in life having a lower risk of malignancy in the radiation field. So certainly one would be even less willing to go ahead with radiotherapy in very young patients, particularly now that there are drugs on the horizon, not just bevacizumab, but brigatinib, that may be potential for treatment, particularly in meningiomas in NF2. So the conclusions to the radiotherapy section is that radiotherapy seems to be associated with around a 5 to 6% rate of malignancy, malignant progression. there has still, to my knowledge, never been a case of MPNST published in NF2 in a patient that has not been irradiated. I've never found a case that has been published. And yet all of the publications on malignancy in vestibular schwannoma are after radiation in NF2, including the 3 in this series. So we've sort of coming to the end here. I've mentioned about the name change. We have had extensive discussions with patient groups, especially in the United States with the CTF charity. We did go through a period of trying to think, would Merlin syndrome or Merlin schwannomatosis be better than NF2, dropping the NF? But the Human Genome Naming Committee refused to change the NF2 gene symbol. They did, however, agree to remove neurofibromin 2 as the gene name. So NF2 no longer has neurofibromin 2 as the gene name. So the new name that was agreed and has been published in the Genetics in Medicine criteria paper is NF2 related schwannomatosis. So remember that Bill will fine you if you say neurofibromatosis type 2 from now on. And these are the many people to thank from the genetic register, the cancer register for all of the epidemiological studies, the fantastic NF2 clinic we have in Manchester, particularly the great work I've done with Dick Ramsden over the years, but also Andy King now taking over the mantle. And obviously this is the skull-based team. You might recognize one or two of those faces. Thank you very much.
Hello, my name is Dr. Kevin Peng, neurologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.